Setting up your presentation at all?
No, I think, how do I get to the presentations?
10:45.
Perfect.
Synced. And on the title slide, you're good.
What's that?
Yeah, you can go up and on the title slide.
Yep.
All right. Your auto advancer's right there. Anything you need, just come up and find us. We have the black shirts, black bubbles.
Okay.
That's a giant bug.
That's the only way that has any chance of legitimacy.
Okay.
Okay, it's 10:45. I think we're going to go ahead and get started. Thanks everyone for coming. This is the Pulmonary Nodules State-of-the-Art Rapid Fire session. My name is Alex Chen. I'm a pulmonologist from Washington University School of Medicine in St. Louis. The goal of this session is to cram as much information in a short period of time. So what we've asked the speakers to do is to give focused, concise 10-minute presentations on a number of subjects. So we're going to go ahead and get started. Our first speaker is Nicole Tanner. She is coming to us from the Medical University of South Carolina. Let me see if I can make this work. There you go. Thanks, Nicole.
Good morning, and thank you, Alex, for having me. I was asked to speak about guided bronchoscopy and its role in peripheral pulmonary lesions. Just by show of hands, how many in here are doing navigational bronchoscopy of some sort? Okay, so about 50% of the room, perhaps? All right, so these are my disclosures. I do have some grant funding and some consulting funding for biomarkers looking at pulmonary nodules as well as devices to evaluate pulmonary nodules. And so I'm just going to do a brief question. And this is not an audience response session, but what is the yield for guided bronchoscopy in the diagnosis of pulmonary nodules? Is it A, 70%, B, 50%, C, 35%, or D, all of the above? Right? Okay. D, all of the above. Good. And I'm going to explain to you why. So if you look at the ACCP guidelines published for diagnosing lung cancer in 2013, this is when the recommendations really changed. And so I point you to this grade 1C recommendation. In patients suspected of having lung cancer with a peripheral lung nodule, a tissue diagnosis is required due to uncertainty. For instance, this person can't go on to have surgery. Radial EBUS is recommended as an adjunct imaging modality. The next recommendation is that in patients with peripheral lung lesions, difficult to reach with conventional bronchoscopy, EMN or electromagnetic navigational guidance is recommended if the equipment and the expertise are available. And so this was in 2013, and I think the landscape kind of changed at that point where we started to think and believe we could do more, get diagnosis of these peripheral lesions using bronchoscopy. And so this is large, I think one of the recommendations was largely based on this meta-analysis, which actually came from our place, looking at 39 studies with over 3,000 patients with 3,000 lesions using a combination of guided bronchoscopy techniques. And what they found was that the weighted diagnostic yield for all of these studies was about 70%. So 70% of the time you could get the lesion, but if you look down deeper in a small lesion, less than 20 millimeters, the diagnostic yield was a little bit better than a coin flip at 61%. In the larger lesions greater than 20 millimeters, yield was 82%, again with a low pneumothorax rate, low chest tube rate. So this seemed to be a possibility, especially in those that might be high risk for CT-guided biopsy. But moving forward by a couple of years, we then have the Acquire Registry, which gave us results that were a little bit different. And so the Acquire Registry was a registry held by the American College of Chest Physicians at 15 centers, looking at 581 consecutive patients undergoing bronchoscopy for a peripheral lesion. And what you'll see there is that without using any of these fancy techniques or platforms, the bronchoscopic yield was higher, 64%. Whereas using radial EBUS alone, 57%, electromagnetic navigation, 39%. So all of these numbers are kind of counter to what the meta-analysis had showed. Fast forward again, in 2005, there was a study published in the New England Journal looking at a genomic classifier to be used during the time of bronchoscopy. The rationale for this study was that bronchoscopy is often non-diagnostic in patients who have pulmonary lesions. And so you do the bronchoscopy, you think you're going to get the answer, but then you're left with non-diagnostic or benign lung parenchyma, and you're forced to do additional invasive testing to try to figure out what's going on. And so the premise behind this study was to evaluate the effectiveness of using a bronchial airway epithelial gene classifier to help improve the performance. And so this was done at 28 centers with over 630 patients, and a brushing is taken in the main stem of the airway during the time of bronchoscopy. So what they found was that 43% of the patients undergoing bronchoscopy were non-diagnostic for lung cancer, and 35% of patients with benign lesions went on to have additional invasive procedures. In the intermediate risk group category with a pretest probability ranging from 5 to 65%, 83% of the bronchoscopies were non-diagnostic, and that is despite a cancer prevalence of 41%. So in patients with an intermediate pretest probability of cancer who had a non-diagnostic bronchoscopy that then had this brushing, if that was negative, this improved the negative predictive value. But the reason I bring this study up is it just highlights that kind of in real-world settings, as it were, bronchoscopies were non-diagnostic for peripheral lesions a lot of the time. when you look at this study that was published in the New England Journal, so there's like lots, or not New England Journal, the Blue Journal, there's lots of different rates of yield. And so this was done in Japan, comparing a very ultra-thin bronchoscope with navigational bronchoscopy. 4 centers in Japan, nodules had to be less than 30 millimeters and randomized 1-to-1 to the thin scope, which is a 4 outer channel with 2 millimeter working diameter, or an ultra-thin scope, which is even smaller at 3 millimeters. Then they use fluoroscopy, virtual bronchoscopy software, and radial EBIS under conscious sedation with transbronchial biopsies for 10 visible specimens. And their diagnostic yield was actually quite good with the ultra-thin group with a 74% diagnostic yield versus 59% in the 4 millimeter scope using guide sheath. But again, 4 centers in Japan. So our group just recently published, and this is available online now, a study comparing conventional bronchoscopy. Our premise was that most folks aren't using navigational bronchoscopy, and standard is fluoro with the standard bronchoscopy scope. And so we used the 4 millimeter ultra-thin scope with a rotating head, radial EBIS and guide sheath to figure out what the diagnostic yield. This was in a randomized fashion at 5 different centers. And 221 patients were randomized, and ultimately 85% underwent standard bronchoscopy with fluoroscopy, and 112 had the thin bronch with radial EBIS, and there was an opportunity for those in the standard arm to then cross over to the thin bronchoscopy arm, and you'll see our diagnostic yields were not very good. Standard bronchoscopy, about 37%. Thin bronch plus radial EBIS was slightly higher at 49%, but did not reach statistical significance with that crossover. 15% more patients were able to get a diagnosis. And so I just want to summarize these studies for you very quickly and kind of comment on why things are going as they are. So in 2012, there's the meta-analysis, and this is a compilation, when you go back and look at those 39 studies, of largely single-site retrospective studies from high-volume centers of excellence, many centers of excellence in Japan and in Germany, and it's repeat authors, and there's very few single sites that are entered in there. So that might have been why the diagnostic yield was so high. The ACCP guidelines, for which the evidence is out there, is the same. The retrospective and a lot of single center studies. If you look at the Acquire Registry, this is a little different. Multi-center prospective data registry. There was both academic and community patients. There were large numbers, but this was potentially confounded by selection bias. And why do I say that? You saw the yield with EMN was much lower, and perhaps folks were going for smaller nodules because they had the technology. If you look at the AEGEA study, which was that New England Journal paper that I presented to you, it was academic and community centers with large numbers. The endpoints were very well defined, what is benign and what is malignant. And then our trial, again, was multi-center, 5 studies, randomized controlled, with very good endpoints. And these were academic centers only. So why? Why are we so bad, or why are we not as good? I think that it likely has to do with the high concentration of publications from high-volume centers with special expertise. I also think if you go back and look at these papers, the definition of diagnostic yield is not uniform. And oftentimes there are abstract presentations and they say, oh, our diagnostic yield was this. But when you look at what the definition of a benign biopsy is, if it's lung parenchyma with no signs of inflammation, that's pretty much non-diagnostic. And if you're going to call benign lung parenchyma diagnostic, well, you probably missed the lesion. So those types of definitions really need to be out there. So a benign lesion would be something, an alternative benign diagnosis like a granuloma, perhaps inflammation, those types of things. So the definitions of diagnostic yield have not been uniform throughout a lot of these studies, and there's missing information, inadequate follow-up. For instance, they're not following those benign diagnoses out with CT scans to see what ultimately happens. I also think that needle use might be part of it. In diagnostic cases, in one paper that was published by Alex from his institution, the yield using TBNA was up to 80%. And so our trial did not use a needle because there was not one approved for guide sheath at the time of the trial. There's also this notion of concentric versus eccentric ultrasound views, whether or not you can get straight into it. The concentric view is a little bit better. And so, you know, it might just be selection as well. So to end, I think guided bronchoscopy for peripheral lesions might not be as good as we think it is. And you have to keep in mind that CT guided biopsy for some of these lesions, the diagnostic yield is upward of 92% every time. Of course, that does come with some risk of pneumothorax of about 15%. So I would say the take-home point here is just because you can, just because you do have that fancy platform, it doesn't mean you should. I think patient selection is very important. The location of the lesion and the size is very important. So guided bronchoscopy might be good for larger upper lobe lesions that have that bronchus sign on CT scan, and if you can get a concentric view with radial EBUS, and maybe with the addition of TBNA, yields will be higher. I think future work is needed to improve the technology and the technique. Currently, there's a trial lovingly called the All-in-One trial, where they're doing guided bronchoscopy as well as percutaneous biopsy using one of these navigational platforms. That should be interesting. And there's also the dawn of robotic bronchoscopy. Dr. Chen presented some data in a late-breaking abstract yesterday showing a really good yield in cadaveric studies of peripheral pulmonary lesions using this robotic platform. All of this stuff comes at a cost, so I think we need to be cognizant of that. And we try to do what's best for our patients. If we're going to be giving them multiple procedures because we want to try out our new toy, isn't necessarily the right thing to do. So I would just leave you with that, and thank you for your attention.
Thanks, Nicole. That was great. We're going to save, for the sake of time, we're going to save questions till the end. That was right on time. I will give a reminder to the speakers, if they go over, they will be shut down. All right, the next speaker is Dr. Gerard Silvestri, who joins us from the Medical University of South Carolina.
It's South Carolina Day here, folks. And by the way, I'm giving a talk on why peripheral bronchoscopy is not very good tomorrow and reviewing the evidence. You'll see some of the same slides. We trade slides so much, nobody knows which slides are whose anymore back home. So these are my disclosures, but they're all research funding only. I do not do any kind of consulting or paid presentations. When it comes right down to it, what's the singular question we really want to answer, right? There's a single question here. You know, is this cancer or is it not? Right? We can talk about bronchoscopy and all these other things, but this is the question that I'm going to spend the last some number of years of my career trying to answer, and our lab is very interested in it. And we've kind of developed this framework for the evaluation of pulmonary nodules. I remember sort of drawing this on a napkin, and Nicole made it into a much better slide than my napkin. But we've been trying to work in all of these areas, and the one area I'm going to talk about today is biomarkers. And so there's incredibly cool principles to biomarkers. They're objectively measured indicators of the state of an individual's health. They range from commonly measured things like vital signs to complex molecular signatures. A new biomarker can improve on currently used tests if it can be more accurate, less invasive, less expensive, and or it's novel in its intent. To have a clinical impact, you have to affect the decision you're about to make. If it's not going to affect decisions, then it's not going to help you move the patient to the next level. This statement from Peter Mazzone, who I think is still in the audience, and by the way, Peter, can you just raise your hand? I know you don't like to do this. You're very humble. You're looking at the new editor-in-chief of the journal Chest, folks. That's Peter Mazzone. I don't think he takes over till June, and he probably is going to hate me for saying this. But anyway, Peter convened a group of docs and got together and developed what I think is going to be the classic paper for how to develop a biomarker. And, you know, a few quotes from that paper. A lung nodule biomarker should improve on the accuracy of clinician judgment, make us more confident. I like to call this confidence building in what we do. Lung nodule risk calculators and PET imaging alone or in combination. It's got to be better than that. If it's not better than the Swenson model, why would we use it? The accuracy of a biomarker should be high enough to suggest that it could move the pretest probability from one end of the malignancy spectrum to the other. So from that middle ground to we want to surveil this patient if it's a negative biomarker to we want to operate if it's a positive biomarker. The consequences of applying the biomarker, if the result is interpreted as positive or negative, should lead to an improved clinical outcome. So we got to know what to do with nodules here, and we're considering molecular biopsies, markers, and it has to assist us in lung volume management. Now, this is the two key points of takeaways from here if you're going to put one of these into practice. Either an early diagnosis of malignant nodules without increasing the number of procedures on patients with benign nodules. That's the trade-off, right? If you have a positive result, are you having too many false positives? Additionally, if you have a negative result, fewer procedures in patients with benign disease without increasing the delay in a diagnosis if you have a false negative result. Those are two important concepts that we have to get our mind around. So this is kind of Pierre Massillon was nice enough to lend us a slide, but this is like that group that I've been thinking about. It's that middle ground, indeterminate pulmonary nodules. Look, if you know somebody's low probability, 5, 10% or less, you're just going to follow them with serial radiographs. If you know somebody's high, greater than 65, 70%, you're going to go ahead and send them to surgery for resection, right? It's that middle ground where we do either PET or bronchoscopy that you want to squeeze people out of. So a negative biomarker in that middle ground could push someone to surveillance. A positive biomarker, if that's the test, will push someone towards surgery and get them out of this extra testing in the middle ground. The other thing I would point out to you here is this idea of using radiomics. And on that napkin diagram that I showed you, you know, our lab is saying, like, wait a second, we're all working in these silos. What we really want to be doing is combining these technologies together. So a prediction model along with radiomics, maybe along with a biomarker, so that we can use every piece of information available to us. So the one other thing we have to know about biomarkers is true positive results are individuals with malignant nodules that could be identified sooner. True negatives are individuals with benign nodules that could avoid costly or invasive testing. False positives are individuals with benign nodules that could undergo costly and invasive testing, including surgical resection, but have benign disease. And just so you know, look at the surgical literature, anywhere from 15 to 40% of nodules that are resected are benign. That's like really unbelievable, right? We want that to move that to 10% or less. False negatives are individuals with malignant nodules that may not receive diagnostic evaluation, potentially delaying treatment. The cost of that delay is unknown, but it's something that I think we need to try to find out. This is courtesy of Peter, but I really love the framework here, right? If you have something with a 90% sensitivity and specificity, you'd expedite treatment. This is the positive one. In 18 patients with cancer, you'd avoid treatment in 72% of patients. But again, there's a trade-off. Unneeded treatment in 8 people with benign disease and delayed treatment in 2 patients with malignant. Now, what if you had a biomarker that was designed to have a high negative predictive value? This one right here. 90%, but the specificity wasn't high. In this group, you'd only be able to use 42% of the results, right? You'd avoid treatment by -1 in 40%, but 2 people would have a delay in their treatment. So those are the only usable results out of that 100, right? Because the specificity is not high. Now, what if you had a biomarker where you wanted 50, you had a 50% sensitivity, but it was a rule-in biomarker. In that group, you'd only be able to use 18 of those results because you'd have 10 where you'd expedite treatment, and 8, unfortunately, that would get treatment for benign disease. Now, as the pretest probability goes up, that positive biomarker performs better, and the negative biomarker with a low specificity performs worse. So it depends on where you are and what your biomarker characteristics are. I'm going to skip that slide. So this was just published in Chest, and I was lucky enough to help lead the national trial along with Nicole and others. And we had a prospective multi-center trial, 33 sites in North America, 685 patients. Eligibility is in that nodule range that we want to think about, 8 to 30 millimeters. This was a combination of an integrated biomarker which used clinical predictors, 5 clinical predictors out of the Swenson model, and then 2 plasma proteins, one that predicted cancer, one predicted no cancer. And it was a clinical assessment. A nodule pretest probability for malignancy was provided by physicians at enrollment. So physicians said, I think this is a 30% chance of being a cancer, a 60% chance of being a cancer, et cetera. The prevalence of cancer was 16%, and if you look at how they based the biomarker, this was a rule-out test. This is a rule-out biomarker. So it was 97% sensitive, 44% specific, and the NPV was 98%. So in this study, if it had been used to direct care, and what I want to mention here was none of us knew the results of this biomarker. We just sent the blood off to the company and managed the patients how we would have normally managed them. So important, right? That's an important thing. In this study, if we had used the results to direct care in every patient, which is unlikely, right? But let's just say we did. 44% fewer procedures would have been done in patients with benign nodules. That's pretty good stuff. You avoid procedures in about half of the benign nodules. However, 3% would have been misclassified, so 3% false negative rate, and those you would have delayed your diagnosis. The question is, what would the penalty be? And all these patients would still be pushed to surveillance. You'd still get a CT in 3 or 6 months. So we don't quite know if that's a big penalty or small one. My guess, having done this for a bunch of years, is it probably wouldn't penalize you very much, probably. And here are the receiver-operator curves. The classifier outperformed PET, the Swenson model, the VA model, and you can see that the high curve up top is the curve there. This is courtesy of Jim Jett, who is my mentor and friend. This is from Oncommune, the early CDT Oncommune test, which is a rule-in test. It's an ELISA panel of seven, you can see here, P53 and 7 biomarkers. And you can see the receiver-operator curve on that. They're due to report a randomized controlled trial on screening. I think it's about 12,000 patients in Europe. But that's a rule-in test. Just want to finish up. There's a difference between doing these tests and having clinical utility studies. And clinical utility studies are very important. That's where you can either use your biomarker and then randomize patients into, we're going to tell the doctors what the biomarker was and direct their, have biomarker strategies, or just let them manage the patients. What we need to see from these clinical utility studies is that you're moving patients, you're believing in what the biomarker says and moving patients differently, either into a rule-in test or a rule-out test as you go along. And the problem is we don't have a lot of clinical utilities tests. We're starting to discuss one with the Expressus biomarker. But here are just some platforms for, and this is taken out of the paper on biomarkers. This is some strategies that you could use. I'm not going to go into detail here, but just to let you know, there are different ways you can assess clinical utility. I kind of like biomarker strategy D, where you'd randomize and you'd either get a biomarker positive that would shunt you into one direction, or a biomarker negative that would be in one direction, and then the other half of the group would get a standard of care approach. I kind of like that one, but they're legitimate. All of them are sort of legitimate strategies. These are just, this is, Katie Sears put this together and then gave it to Nicole Tanner, who gave it to me. So I'm on the third person using the same slide. But essentially, this is what we have sort of out there, the different trials. I would just point to the right-hand end of this, which is some of them have CMS approval, some of them are going into clinical utility trials, some of them aren't doing anything just yet with their data, some of them I'm not even sure are still in business, but this is sort of what's going on out there right now, and there's probably 10 companies that haven't been mentioned. I can tell you this is probably the hottest area in nodule management. So just to summarize, most patients that we see fit into this large intermediate group of risk. We don't see as many patients on the lower end, 5% or less, or on the upper end, 65% or more. This is the group we really need to deal with. Any diagnostic test that reduces invasive procedures when the nodule is benign or gets patients to surgery with minimal testing when it's malignant is a great biomarker. So when companies approach me or researchers approach me and say, what would be a great biomarker? I'll tell you what would be great. Sensitivity 95%, specificity 95%, right? But that might not be available. There might be trade-offs. And so rule-in biomarkers will occur and rule-out biomarkers will occur. So, we got to keep the non-usable tests to a minimum, right? So if you send away 100 patients with a biomarker test and only 40 of them are usable, then you've spent money on 60 that are not usable results. Combining platforms, I think, is incredibly important. Prediction models plus a biomarker plus radiomics is likely to produce incredible receiver-operator curves. Unfortunately, we're all kind of working in silos. We're trying to break those down, but unfortunately, we're doing that. And then clinical utility is needed. Will doctors have the confidence? I'm really starting to think about this word confidence. Will they have confidence to act on the results of a biomarker test, to change their strategy and manage people in that regard? So anyway, I thank you for your kind attention, and I'll be finished up there. And I'm sorry, I thought that was the last slide. Are biomarkers ready for prime time? I think they're close, but not quite. I want to see clinical utility studies, but I think they'll be routinely used in the next 5 years. And that's the acknowledgement to our team and some grateful slides from that crowd right there. Thank you.
Right. Thanks very much, Gerard. I'm going to skip ahead to my talk. Again, my name's Alex Chen. I'm not from South Carolina.
But you wish you were.
Maybe, maybe. All right, so I'm going to shift gears a little bit, talk more about procedures, and we'll talk about this growing era of robotic technology. So my disclosures, I've done consulting and received some research funding from Auris Health and Intuitive Surgical. I've done some consulting. Both these companies make robotic endoscopic platforms. So just to put things into context, Nicole went over this very, very well, but why traditionally have we had challenges with conventional bronchoscopic approaches? And I'm now talking about conventional approaches as being electromagnetic navigation, radial EBUS, and not just plain transbronchial biopsy with fluoroscopy. One of the challenges that I face are that when we have these anatomical relationships where the lesion sort of sits right around the airway, we've documented that the diagnostic yield there is good 80% plus, and that's been replicated in multiple trials. However, when we have this relationship here where the airway sits adjacent to the peripheral lesion that we're biopsying, reproducibly that number is about half. It's anywhere in that 30 to 40% range, and unfortunately, we just don't get to pick where the nodules are. Our radiology colleagues don't care because they just go right through the lung. As far as we're concerned, we are to some extent confined to the airways as we're doing bronchoscopy. So what role could robotics potentially play in all this? Well, I mean, it's a fresh look. Think of it that way. It doesn't exist. It's the ability to build something brand new. If you could build a scope the way you wanted to, is this the opportunity to have some type of disruptive technology? Also, it can incorporate some of the newer technologies that we've been accustomed to using. So it's not working in a silo. It can incorporate things like navigation or radial EBUS or virtual bronchoscopic navigation, and the instrumentation may be improved to some extent. Again, this is building from the ground up, so you sort of get to put your wish list together and say, what are the things that would be important to you and what are the things that actually might allow us to biopsy things better? So what kind of data do we have? Well, there's not a lot of data. There's a lot of excitement over this, and I would say rightfully so, but in terms of what we have to look at from the literature, there's not that much. But we do have a couple first in use in humans already. So at CHEST last year, the Australian group presented on 30 patients undergoing robotic bronchoscopy for lung nodules. This is using the Intuitive system. Nodules 10 to 30 millimeters in diameter. The diagnostic yield reported there was 83%, and there were really no significant adverse events. Now, again, this is not powered for yield. This is just, is it possible to do, and does it harm anyone in the process? That study showed that it did not, and this is still in abstract form here. This was published earlier this year in the Journal of Bronchology using the Auris system or the Monarch platform, and it showed feasibility in 15 patients who underwent bronchoscopy, robotic assisted, and were able to get diagnostics or specimens in I forget what that number was, but it was a safe procedure, and it didn't, they didn't have any significant adverse events. This was using an older system that was probably a few years ago. So first in man has been described, robotics have been described in human beings. So what are the clinical problems that we put? If we frame this in the work, that one of the challenges that we face is that we still have a hard time biopsying these things that are adjacent to airways. How is it that something like robotics could potentially be of some assistance? Because beyond all the hype, we have to understand where this technology potentially fits into our workflow, and if it doesn't address some type of need that's correctable, then it probably doesn't have a place in what we're doing. So one of the options is a reconfigured scope design. So if we can build a new scope from the ground up that acts in a different way than our conventional scopes, is that something that would be beneficial? Is improved maneuverability and control in the periphery? So once you get out further into the lung periphery, do you have better control of instrumentation that may allow you to biopsy some of these things that are adjacent to the airways in different ways? So one of the things that we looked at doing was trying to prove where this technology actually fits in. One of the systems using the Monarch platform, the scope using that is 4.2 millimeters. Well, we have scopes already that are 4 millimeters or 4.2 millimeters, and we have experience using that. So how is it that a scope of the same outer diameter is actually going to get us anywhere further into the lung? How do we look at that? How do we prove it if it's possible? So the configuration of this platform in particular is that it's a mother-daughter configuration. There's an outer sheath that's about 6 millimeters, and then there's an inner scope that extends throughout that. The two can be driven independently or in combination, and so you can kind of park a scope somewhere and then go further if you want to with the inner scope, and that which is 4.2 millimeters in outer diameter. So we look to prove this in a cadaver model to see if, in fact, the robotic system could outperform a conventional bronchoscopic scope of the same outer diameter caliber. So this was done with 10 operators and 5 cadavers using a 4 millimeter scope and the robotic system with identical outer diameter. And we measured peripheral axis generation count, bronchus generation count, as well as insertion depth as measured by electromagnetic navigation and external fluoroscopic images. So this is data that we presented at this meeting last year, where 8 segmental bronchi were evaluated in 5 cadavers. In general, the robotic system accessed 9.6 generations on average, compared with 6.6 generations using the same caliber thin bronchoscope. This is a superimposed image of what that looked like going into the same segment, the apical posterior segment of the left upper lobe. You can see here the shadow of the conventional thin bronchoscope, which stops right here. We've had this experience before where at some point the scope gets wedged, you push, and the scope becomes prolapsed. That's what we saw here instead of going further. This is the outline of the robotic system. The outer sheath is parked here at the orifice of the left upper lobe, and then the inner scope extends a little further into the periphery. So what we did was we tried to validate these findings using a little bit more of a regimented protocol. And so we used 2 cadavers and compared them, the 2 scopes once again, in randomly generated pathways. And this time we actually looked at all the segments. So we actually cannulated randomly generated airway segments, all 10 segments on the right and 8 segments on the left. And this is a sort of a busy chart showing the results of that. But in general, the results were about the same. The robotic system was able to go a little further into the periphery than a conventional scope of same caliber. In some instances, that was just a little bit. In some instances, it was up to 6 generations further. Sort of, there's a large variation, but those results were fairly reproducible. This is what some of those images look like, and this was just recently published this year in the Annals of Thoracic Surgery. Top row is conventional thin bronchoscope. Here is the robotic system going to those same parts of the lung. So you can see here in each of these examples that the robotic system was able to get further into the lung periphery than the same size conventional bronchoscope. This is a distant measurement here. So the highlights, the configuration and maneuverability of the robotic system appeared to improve access and reach into the lung periphery compared to similarly sized conventional thin bronchoscope in a human cadaveric lung model. So the questions that we came out of this study with were, all right, so is there any overt injury to the airways? Because as you all know with bronchoscopy, you get into a segment and you're going to get some resistance and you kind of know how hard to push. There isn't that feedback with the robotic platform, and that's one of the things that we're interested in looking at in live human tissue. There was no overt signs of airway injury when we did our inspection, but again, it's cadaveric lungs, and how well does that translate into live human tissue? It's a little unclear at this point. The other question is does additional reach into the periphery translate into additional yield? So just so you can get further into the lung periphery, does that actually improve your diagnostic yield? So we followed up the REACH study with this ACCESS study, and I just presented this at the late-breaking abstracts yesterday. But this was sort of, imagine this being target practice. So what we did was we injected a number of artificial tumor targets into the lungs of 8 cadavers. This is what one of those artificial tumor targets looked like, and it was a gelatin agar mix. And we created these lung nodules sized 10 to 30 millimeters dispersed throughout the lungs. 8 cadavers were prepped, 8 operators did bronchoscopy. There were a minimum of 8 targets per cadavers. After the nodules were prepared in the cadavers, all of them had CT scans so that we can use them as a map during bronchoscopy. The system was used to biopsy tumor targets, and we used radial probe and bronchial ultrasound to confirm the presence of a lesion prior to taking a biopsy. The endpoint here was yield. We're just, like I said, target practice. Could we actually hit these nodules in the periphery of the lung? During the procedure, cadavers were intubated and ventilated to try to mimic an authentic sort of bronchoscopy experience, if you will. Fluoroscopy was used in all cases. Electromagnetic navigation, which is incorporated into these robotic systems, was used also at the discretion of the bronchoscopist. Again, radial EBUS was used. This is what one of the images looked like of a lung nodule. TBNA was performed as a biopsy of choice in all specimens. Additional forceps and brushes were taken if desired, but TBNA was required. And then there was the microscopic identification of pigment and powder, which was composed in the lesions, was indicative of whether or not you actually hit the lesion with your needle biopsy. So the results here of 67 lung nodules total, 59 or 88% of those were actually identified using radial probe EBUS. Of those, the breakup was 81% of those nodules demonstrated an eccentric view. Historically, those are the ones that have given us a lower yield, and 18% of those had a concentric view. The overall diagnostic yield here was 97%, or 65 out of 67 nodules were felt to be successfully biopsied using this approach in this model. Broken down by size, 100% of nodules 21 to 30 millimeters were successfully biopsied, and 44 out of 46, or about 96% of nodules between 10 and 20 millimeters were biopsied successfully. So last slide here, where are we and where do we go? So I think to some extent we've demonstrated reach and precision in the lung periphery in cadaveric models. And that's important to note. These are in cadavers. Are these results reproducible in living patients where we have other things to think about, like airway trauma and the elasticity of the lungs as we're able to get further out? We have things like respiratory variation, coughing, secretions, those types of things. In addition to that workflow, so is this going to be a long procedure that sort of makes this sort of untenable for most of us, or is this something that's going to be as efficient as what we're doing now? Because those things are important in rolling out new technologies. And so by this time next year, we're hopeful to have some more data to present as live subjects are being enrolled in an ongoing study looking at the performance in live patients to validate some of these findings. Thank you. All right, I'm going to invite our next speaker, Momin Wahidi. There he is. So Momin joins us from Duke University, and he's going to speak to us about bronchoscopic ablative treatments.
All right, good morning, everyone. Thanks, Alex, for inviting me. So I'm going to talk to you about bronchoscopic treatment of lung cancer, and this is appropriate to be a 10-minute talk because there's not a lot to show you. There's a lot of concepts and sort of evolving work, but not much today. I apologize, I did not put the disclosure slide, but I have no disclosure related to peripheral treatment of lung cancer. Why is this an important topic? Because the vision is such. Imagine in, 5, 10 years that a patient who's an ex-smoker presents to you with a lung nodule suspicious of lung cancer. The patient is not a surgical candidate. A PET scan shows FDG activity in the nodule. Only the next day you perform a bronchoscopy, maybe with radial EBUS, because I put a very easy nodule here with a highway going to it. And that would be really also appropriate for maybe peripheral bronchoscopic treatment. The rapid on-site pathology team tells you it's adeno, and perhaps you go ahead and treat it in the same session. So that's the vision. And can we get there, and how long is it going to take us to get there, and is it feasible? So just a reminder of the current state. The current state is surgical resection. That remains the standard of care based on the data we know today. When a patient is not a surgical candidate, the first option today is stereotactic body radiotherapy, or Sbrt, and that's also the best evidence we have. Many of you are aware of the VALOR study that's being done at the VA system comparing surgery versus Sbrt for stage 1 lung cancer. That's going to be an incredibly important study, which unfortunately is going to take 10 years, but when I'm a lot older, we'll know Sbrt versus surgery. There's also percutaneous thermal ablation. Today we have Rfa, we have microwave ablation, we also have cryoablation. And then there are the emerging bronchoscopic techniques. I'm not going to talk about the percutaneous options today, we don't have time. I'm going to talk to you about what's going on in the bronchoscopy world, and these are the bronchoscopic technology under evaluation today. Rfa, microwave ablation, photodynamic therapy, cryotherapy, vapor ablation, brachytherapy. Not too much going on, so it was more interesting 10 years ago, but there's still some work on there. The thing, though, is we have very, very limited data on the use of these technologies in human. So a lot of this is being done on animals, so I'm not going to discuss those because of time limitation for this talk. I will mention the two things that are being tried in human and we have some data on. And that would be basically first Rfa. And bronchoscopic Rfa, it's just an Rfa. It uses this interchange radiofrequency electrical current, and it's sort of been described it's similar to a high-frequency surgical scalpel. So it's an ablative technique that can be used in the periphery of the lung. There are multiple studies on percutaneous RFA, but as you can imagine, the literature is pretty weak, actually. And that's why that procedure is not incredibly common, or you don't hear often that patient went for a percutaneous RFA. The literature is scattered, but there's various levels of tumor responses in these case series and reports. I'm not going to put them all there. But there are some kind of alarming things. I mean, there's, in some studies, had technical failure in up to 37%, up to 20% rate of major complications, including hemothorax and bronchopleural fistula. And the most common complication is pneumothorax, reported anywhere between 10 to 57% of the time. So, I mean, that's what makes potentially bronchoscopic RFA more attractive. Could it be more effective? Could it be safer? And can we do it and get better results than percutaneous RFA? So there are two studies I'm going to discuss. Those both come from Japan. Tanabe did the first one, published it in 2010, and this one was really more of he was comparing different catheters, different RFA bronchoscopic catheters of various diameters and duration of treatment. He took 10 patients with stage 1A lung cancer. He treated them with bronchoscopic RFA. They were cooled RFA probes. He used CT guidance to get to the lesion, and they resected those patients. So they saw that clearly the ablation areas were larger if you used a larger tip or longer duration times. That was established, so it's sort of dose-related. This is interesting. The resected tissue contained residual tumor in all patients. So at least at that time, it could not eradicate the tumor. There was no complications. So again, we proved at least bronchoscopic approaches probably can be safe, but at least early on, the efficacy is not there yet. So the same group actually, his colleague Kozayomi did the next study published in 2015. Again, they used CT-guided bronchoscopy, cooled RFA in 28 patients with medically inoperable stage 1 non-small cell lung cancer. This time they did not resect. They just followed the patients with CT. So they followed them with CT imaging and clinical follow-up. So based on follow-up, at least they reported in their report that they think the local disease control was achieved in 82.6% of those patients. They reported a 5-year survival of 61.5%, which sort of compares favorably to the 5-year survival of sort of early stage cancer treated with Sbrt. And no reported serious complications. 3 treated patients experienced fever and chest pain and were managed conservatively with short-term hospitalization. So again, you can see very early, very selected patients, favorable results, but there's definitely a need to replicate those results in a more multi-center, larger fashion. Interesting stuff, if we start doing that, we got to learn about this treatment. And here's an example. Radiologists see that with percutaneous, but here's the lesion, one of the lesions they treated, and that was sort of a mixed ground-glass solid lesions. And you can see 6 months after RFA became this linear line and scarring and kind of persisted 24 months. So if we're going to start doing this, we need to learn about the appearance of scar and how tumors look once we treat them with that modality. And then here's an example of a patient who had a complication 2 weeks after RFA, had that consolidation. Unclear whether that was a pneumonia or inflammatory reaction, but they treated it conservatively, and this shrank and became a scar. So things to keep in mind as sort of evolution of treated peripheral lung cancer. And then the next one we know about is microwave ablation. Has been used percutaneously with variable success. We don't have any data other that we know, this is from clinicaltrials.gov, that there's an active clinical trial now on microwave. It's a multi-center study, 40 subjects, 5 centers in the US. patients with inoperable primary soft tissue lesions of the lung equal to 2 centimeter located in the outer 2/3, all under general anesthesia. The treating physician will use endobronchial ultrasound at the procedure to make sure the lymph nodes are not involved. Patient will be followed for a year. I believe some preliminary results maybe the first few patients are being presented in this meeting, but I don't have access to anything. Nothing is published so far. So this is very preliminary. We don't know anything about microwave ablation in the periphery. We'll await this trial and see at least the preliminary results. So just kind of, let's talk about this kind of the advantages, disadvantages. So let's first tackle bronchoscopic ablation versus SBRT. What could be the advantages? Well, it's definitely cheaper. The average cost of SBRT serial treatment today is around $40,000. It does require multiple session SBRT versus potentially bronchoscopic treatment is 1 session, and there's no risk of radiation pneumonitis. Disadvantages, it's definitely more invasive, bronchoscopic treatment, there's anesthesia, there's procedural complications, and I think we still have lack of precision in nodule treatment, and all the speakers who talk to you about our access to the lung nodule bronchoscopically needs a lot of work. And the bar is different for diagnostic versus therapeutic. Diagnostic, if you brush against the periphery of the nodule and get some malignant cells, maybe that's enough. But with treatment, you really need to know where is your probe, how is it located, relative to the center of the lesion, and how do you plan the treatment? So all these things are not there yet. How about bronchoscopic treatment versus percutaneous approach? I think it's safer, lower risk of pneumothorax. But again, the disadvantages, we're today still less accurate in finding that lesion. Again, you heard the study from Nicole and others. And we do have also an issue of lack of precision on orientation of the ablation probe to tumor to ensure achievement of optimal ablation. I mean, I think this is a point for both. And this always begs the question, are we only going to do these treatment, bronchoscopic treatment, with a CT? Whether it's portable CT or cone beam CT or CT in the radiology department, will we ever feel safe or confident that we can do this without a CT image, intraprocedural CT image, showing you that you're in there, that you are confident that you're delivering the heat, the ablation to that lesion? So I'm going to end with sort of the path ahead. Questions that come to mind as we think about bronchoscopic treatment. How realistic is it to develop this bronchoscopic treatment for peripheral lung cancer in the next 5 to 10 years? It's a very high bar to compete with SBRT, very high bar. To switch from SBRT to bronchoscopic ablation, we will need very rigorous studies. And those are not easy to do, and doesn't seem like anybody wants to fund them. So I'm doubtful, actually, that we can get there in the next 5 to 10 years. What would it take to convince you to send a patient to bronchoscopic ablation versus SBRT that has a really track record? What would it take to convince the oncologist? You're not always the physician referring those physicians. And finally, the question, would we always need procedural CT confirmation? And in summary, I think we should only do this in a research environment. We should not try these bronchoscopic treatment out of a research environment. We still don't know their efficacy and safety. We cannot deprive patients from a better treatment, which is SBRT, unless it's in the research arena. So thank you for your attention.
So apologize, one of our speakers is not able to make it to give his presentation, but does leave us some time for some questions. And I'll invite our last faculty member, Dr. Kevin Haas from the University of Illinois Chicago, to come up and sort of moderate the question and answer session here.
Does anybody have any questions?
You're doing a great job moderating.
All right, thank you, everybody. Thanks, guys. Yeah.
I have a question, actually, if you have a minute.
Sit down, please.
Saman Rafek, NYU. A question is to Dr. Wahidi. Momin, thank you for the talk. I'm curious about the second Japanese study that you presented with RFA. Did those patients have a biopsy prior to treatment, as far as you know?
Yeah, they were confirmed adenocarcinoma.
Adeno, okay.
Yeah.
So the question then becomes, with the 5-year survival, are we dealing with a slow growing adenocarcinoma where even the natural progression would have resulted in a higher 5-year survival rate? So I don't know what your comments on that.
Yeah, no, I completely agree with you. I mean, we don't know the biology of those cancers they did, and I don't know if they're all some ground glass or mixed, and we know some of them are very slow growing, and frankly, patients may die from other reasons, as we know, and they can survive with a ground glass adeno, for decades. So I agree with you. I think that's why we don't put a lot of weight in those studies. It's very selective patient population, and that statement was too strong probably from them that the survival is equivalent to Sbrt, and that's why I think we're not ready. It's not ready for prime time.
Thank you.
I have a quick question. Would you, from a therapeutic standpoint, would metastatic lung nodules make more of a sense for this type of therapeutic approach? And photodynamic therapy, anything on photodynamic for peripheral lung nodules?
So I'll answer the last one. Photodynamic therapy, to my knowledge, has been tried in animals. There's I think one published report on PDT in peripheral lung cancer or simulated or lung models. I'm not aware of anything in the humans. I know there are some people working on it. It's an intriguing idea. It's just sort of, you have to figure out how you disseminate that light in a solid nodule and where's the best location. And the second question was?
The use of this technique, or peripheral or bronchoscopic techniques for metastatic lung nodules. Like if you have true metastasis from like kidney cancer or others that patients wanted treated, but.
I don't know if this is on, but I reviewed a couple patients in the update, the literature review, a couple of papers in the literature review on lung cancer. And so now the staging classification has changed so that we have these patients with oligometastatic disease that are in lung cancer anyway, or the stage M1B single, which is a single focus of metastatic disease. And there are 2 randomized trials now that show a benefit of treating those. Both were actually stopped, small studies, with ablative techniques, and Sbrt was the technique they used in one, and targeted therapy, chemotherapy in the other. I think, so I think there's something going to be changing with this. There's definitely a different outcome with these. I would personally say that I think Sbrt still has the upper hand in treating oligometastatic disease, and some people say up to 3 lesions, either in the brain or elsewhere, can be treated now with stereotactic to the brain radiosurgery, etc. I have to say, Momin did a great job. I do think they overplayed their hand in that study. I think, first of all, the overall survival was actually much better than you should see with medically inoperable lung cancer. Most of the patients with medically inoperable lung cancer died really very quickly from competing causes of death such as COPD. So these patients actually did better in general. And I also think there's a different biology in Japan. We see a lot of patients in Japan that are EGFR positive, that have a different biology, that live longer with their cancer. So I think it was overstated. And I think we are honestly deluding ourselves if we don't understand that the gold standard for medically inoperable is Sbrt, and anything we do therapeutically has to be compared directly in a randomized setting eventually to Sbrt. And if we don't do that and it escapes out, I think we're doing our patients a disservice. And the only thing you need to do to remember that is the fact that all of the patients in the previous study still had active tumor. Every one of them. That's a problem, man. That's a definite problem.
Yeah, thank you.
Just keeping with the theme, Dr. Wahidi, just given the limitations of RFA and the normal lung tissue, heat sink effect, not covering adjacent nodules, do you think most of our research should be focused on PDT and MWA?
I'm not sure. I mean, I think there's still room for research in RFA. You can modify it to fit the lung. I mean, there's been success stories in the liver and other organs. So RFA is used in. So I think if there's a will, it will. I mean, we can test it. We can design different probes if needed. I don't think it's excluded. I don't think ablation or PDT are going to be better. The answer is we don't know which one is better. So in a research area, you should try. Within the research arena, you can try all of them and modify those until we get to that level.
It's all about energy, right? Like I'm pretty hot and interested in Lonnie's here in cryotherapy, right? Like it's all about energy. Incredible cold, incredible heat will kill a tumor. The problem, I think, with all these techniques is can you get the complete area surrounded? So it's more of like an imaging and placement question than it is the energy question.
And I think the onus, the bar is incredibly high to prove that it actually works well too. I don't think this is something where radiographic follow-up cuts it. Because this technology, all of these different microwave, radiofrequency, cryotherapy, all of them they all work differently. They haven't been applied through the lung bronchoscopically in the way that we're intending to use them to ablate tumors. I don't see how you cannot have tissue evidence of the effect that you're looking for. I don't think that's a reasonable thing to do.
I just have a quick question about biomarkers, especially the one that's now available commercially, and some of us are using it, especially Percepta. I kind of want to know, in your experience, how you're using it. If I have an intermediate risk nodule and I do this test and it comes back and tells me it's intermediate risk, where am I going with that, especially with the Fleshner guidelines and in the follow-up? It's really not changing management. So how are y'all using that?
So to be honest, I'm not using it a lot. But if I am going to go down that pathway of doing a navigational bronchoscopy, if I've determined this is a nodule that I think I can get, there's an airway, it looks like perhaps it'll be concentric, we do the test ahead of time, send it off, and that's what's really important, and it's kind of what Gerard showed in his slide. You're only going to get an actionable test result a certain amount of the time. So 100% of you send off 100, you might get a result that you can take action on 40 times out of 100. And so that's really important. You have to know that your risk might not change. So you have to identify what your pretest probability is, and then if it comes back as not an actionable result, it just stays the same, so you do what you would do anyway. So it's nice if it comes back and it lowers the risk and you can feel more comfortable doing surveillance. But if I was that worried to take somebody to bronchoscopy about malignancy and I get a Percepta test that I can't take an action on, I'm just going to treat the patient like I would anyways based on the guidelines. If I was that worried about cancer, I'd probably send for a CT-guided biopsy to determine. So that's kind of how I see it in practice. Folks are using it in different ways, but that's my practice. I don't know if you guys have additional.
And there is a registry for the Percepta to see if it changes management, but I want to throw it back to Nicole. We have a paper under review from our lab where we presented, just call it Biomarker X, doesn't matter what the biomarker is, in 4 different scenarios where we initially presented them the scenario, asked them what the pretest probability of cancer was, they gave us their pretest, then we gave them back what the Swenson model said, right? And then gave them the biomarker result, and I'll let Nicole tell you how great our community is at managing things.
Right, so the answer is they're not that good. So this was a survey study of 490 thoracic surgeons and pulmonologists, and we gave them these vignettes that took them through the case, and at the end we said, this is the pretest probability. Now here is the test result from this biomarker. And it's a rule-in test, by the way, and it's going to change your pretest probability to this. What would you do? And oftentimes, there was one case in particular where it was not an actionable result, and we said the pretest probability goes from 20% to 20%. There is no change. And folks were changing their management strategy based on a non-actionable test. They were doing surgery in something that had a test result that made no difference. They should have just continued what they were going to do anyways. Again, it's a survey study, and there's some biases built into that. You want to click through so you get your Amazon gift card at the end. But this is very real. So I think as we roll out biomarkers, the education on how to use them and interpret the test results is so important. Otherwise, we're going to cause more harm. I mean, just using guideline care, we've shown in multiple ways that physicians don't follow the guidelines even when they know what the pretest probability risk is. And so if you add in a new test, a brushing, a genomic classifier, a blood test, if you don't educate the user how to use it, we could do more harm than good.
Just by the way, in that study, thoracic surgeons, we asked them, how confident do you feel in managing pulmonary nodules? Thoracic surgeons were way more confident than pulmonologists, way above 90%. Oh, and not surprisingly, Almost didn't matter what scenario presented.
They did surgery.
They did surgery, you know? So, I mean, like, these are all, we laugh, right? But we're not, look, we need to take ownership too. We're not as good as we think we are, even though before the study, before they got the vignettes, we asked them how confident you are. And their pulmonologists are confident that they know what they're doing with nodules. And they, you know, so like there's a lot packed into this whole area that has to get, but education's gonna have to be right, you know?
I also worry that all the previous models that we use, I mean, expert opinion or an expertise is as better as any prediction model if you really think about it. The better you are at doing this a number of years has to have something to do with
Sure.
a prediction model. So unless it's a study that has a standard prediction model that's being used by everybody, in that study, pretest prediction model, it would be difficult to interpret the results as well.
Well, yeah, and we did show that clinicians, at least in this 133-center trial, were better than the models at predicting benign versus malignant. But the other thing about risk prediction models, and we had to talk about this yesterday, is that it really depends on the prevalence of malignancy in the population that you're using it in. So if it's a screened population, the prevalence of malignancy is anywhere from 3 to 5%, so you'd want to use the Brock model. If it's like, you know, a regular patient presenting, you might use the Swenson model. If you're at the VA, prevalence of malignancy is higher, so you would use the VA model with a prevalence of malignancy of 40%. So you have to choose the model based on your population, and sometimes people don't get that. Hi, Arnie.
Hi. I just want to mention something about biomarkers also. We do that all the time in pathology, and they can be done sequentially. So, for instance, the point is that you were making before about rule in, rule out. We do this every single day with HIV, and namely, we have this terrible, terrible test that picks up everybody, people with lupus and so forth, and then we do, you know, the more specific tests and so forth. So just imagine for a second you have a biomarker which is 100% sensitive. It misses no one. But because where you draw the cutoff, it is terrible when it comes to specificity, right? No, that your ROC curve is basically a decision where you move that line, right? Who gets admitted because they have a heart attack and who gets sent home, depending upon what your troponin level might be, even if it's on the cusp. So if you have a test that is 100% sensitive, you don't miss anybody, no false negatives, and it's partially specific, then you say, okay, fine, I have now my umbrella. Now let me take another biomarker sequentially and look for a test that is terrible when it comes to sensitivity, but I don't care because I already have my umbrella in terms of gathering that crowd. And now I have a test that's 100% specific. So obviously, if you did them by themselves, you would have tremendous amount of error. But if you do biomarkers, depending upon the nature of the exam, in a sequential fashion, you can actually get results that may be helpful.
Yeah, and so that's why I asked one company if they would sell themselves to another company, and we could get that perfect biomarker.
All right, thanks, everybody.
Strong work, House.
I think there should be more line.
That's true.
How are you, Arnie?
What happened to you?
Yes, I do. For you, always.
It's a total, I was so looking forward. It was a good time. I fucked up. I had a double block. I totally. You were double booked for time? Yeah, I screwed it up. My timing was. That was the first time I ever. Like, to see you.
We were just talking about how brilliant you were.
Yeah, the double block. Right. Yeah, no, but so and then there was
biology within the audio may not be everywhere. But we're reaching every audio, but we're not getting anything.
How do you know you're reaching every number?
Well, we didn't leave us one, and two, based on the EMN.
Yeah, so the event is not, you don't know. I mean, there's no way you would.
We're getting eccentric views in most.
Well, and that might be the reason, right? I mean, so the diagnostic yield of 40%. I actually think the model in the cadaver
No, but what about, you don't think it's the material that you use is just easy to get, even if you get the quality?
That's not it at all.
Okay.
It's a cadaver model, and it's difficult to apply those to live patients. So we expect those numbers to go down in live patients, but the experience is still good. So I don't know. We're gonna do a pilot study as well, a multi-center study. We're actually getting the system installed this month. So we'll be happy to compare notes. Nope.
Yeah.
No, I talked to Kyle earlier today. He's happy with how it's working. Great.
So that would be both diagnosed.
But maybe it's not the right
But
one.
that-
Yes.
How are you? Nice to see you again.
Yeah, so I ran into Praveen earlier.
Oh, good.
Yeah, we have like 15 or 18 former fellows all at this.
Oh, that's great. Now I heard you guys do like a get together, right?
Yeah, we did last night.
That's great.
And I went over to that other meeting, but yeah, there was a bunch.
No, that's fantastic.
Yeah, I'm trying to get cryo going now, so it's because we're starting an interstitial lung clinic, so the needs gone up. So
Got it. That's
but
great.
I'm trying to make sure it's all done right.
Well, that would be the key. That would be the key.
Not easy, so I'm gonna get a hold of you at some point.
Absolutely. Nice to see you again.
Right.
Even though what we found is no one's going to do
Did you really?
it's going to be two separate.
Right.
Because you know you want to do
Right.
an R1 section. You know that.
You should be like having a little hard time.
So, anyway, that was the point I tried to explain to you. That there's a difference I couldn't make the Sunday meeting because we came late. But I spoke to this one teacher Monday, Manchester. Which always went to him the difference between a cerebral biopsy, which is diagnosing, and so her biopsy, which is diagnosed tick. Cerebral biopsy, which is diagnosed tick.
Miss the lesion, right. Did you get it?
I think
Yeah. And Lonnie's the head of that trial. Lonnie Yarmus, yes.
so hopefully that will be.
Yeah.
Otherwise, how was the horrendous thing? It's interesting. This is the funny part.
Can I, at least out of fun interest, can I at least show you the fun slides? Let's see.
Right.
So
Silvestri. Move. Gerard, move. Dr. Silvestri, please move out of the way of the projector. Right. Oh, why isn't this working? Oh, yeah, so there's that, right?
Oh, nice.
All right, and then here's my lung diagnostic pathway. Right, so it's
What does that say?
perform bronchoscopy. And then I had this, which is, I thought, oh, did I? All right, so that's Bucky Dent hitting the home run in 1978.
That's Boston, I know. That's where I trained. That's 3 blocks from the Brigham.
What other fun stuff? And all this good stuff. Totally botched it. Right. We got that nonsense. And then, hold on, there's flip of the coin.
Donnie, you had an algorithm before.
Oh, this one, my first.
Yeah. Could you send that to me?
Yeah.
You have my email. Just send that to me.
I had wait, there was one other good one. Oh, here, this. Yeah. Alex? And then.
You're welcome.
Right? I know, it was so good. Well, wait, hold on. The best was the arm guy? The little one with the little tentacles. Yeah, you've seen that? I love that.
Thanks, G. You're welcome.
Sorry. Yeah, that's the best. Isn't that the best?
No, drinking.
I've never done this.
All right.
So we made fun of that. I did have it.